Now you can share, sir.
Just a minute.
Yes, sir. Your screen is
Screen is
visible.
visible. It's visible. Okay.
Yes.
Yeah. I'll start.
Yeah, you
Yeah.
can
You
put it
can
on the
put it on the
slide
slide
share,
share,
slide
slide
presentation, and
presentation.
you can
Yeah,
start.
yeah, yeah, yeah. I'll operate. Yeah. Good morning, all. First of all, thank you, our IIM SR chairman, CEO, and then our respected Dean sir, and my dear friend Dr. Shafi, for this fabulous webinar that has been arranged, and very important topic. We're having multiple mechanism and very complex therapeutic aspects. That role has been given to me to discuss with the therapeutic management or recent advances that I'll be discussing on. Uh, the screen is there, no?
Yes, yes,
Yes,
sir.
yes, sir.
But you
But
have
you
not
have
put
not
it on
put it
your
on your
slide share
slide
mode,
share
sir.
mode, sir.
Slideshow mode.
Slideshow mode.
In your
In your
PPT,
PPT, okay.
yeah, yeah, yeah. Put
Now,
it on slideshow.
slideshow.
Yes, from the
Yes, from the
beginning.
beginning. Okay,
Yes,
it's
yes,
fine now.
yes, yes.
Yes,
Very
yes,
much
very
fine.
much fine.
You can
You can
continue.
continue. Yeah. Now the objectives that will be here for this talk: identify mechanism of action of newer antihypertensive molecules. We have many old molecules that we have been using since last over 10 to 20 years, but there is always a need for newer molecules because there is a concept of resistant hypertension or refractory hypertension. Then second objective will be to summarize the indications for initiating newer antihypertensive therapy and to review the adverse event profile of newer drugs. As previous speakers have discussed, hypertension is the most common modifiable risk factor for the cardiovascular events. Almost it is having the 50% uh, burden on the global population, and very important to curtail this at early stage, and that has been a mechanism as well as the epidemiology has been discussed in detail by the previous speakers. I will not go in detail of that. JNC criteria, as you all know, the blood pressure readings when we diagnose the hypertension, that is also discussed as a part of epidemiology by previous speakers. Then the important aspect, essential and secondary hypertension. Secondary hypertension, particularly as a uh, clinical era, we see in the young and when we as a clinician, when I suspect or we suspect secondary hypertension, that is important part is less than 30 years of age, and main aspect is renal diseases in this case. That also will not go in detail. This is important slide that is important from a clinician's or physician's point of view. Resistant hypertension, when do we call resistant hypertension? Almost when we need the fourth drug to add to a patient. And in the refractory hypertension, even the four drugs that is not helping out, and you may need the fifth drug or any other measures. And even with all these measures, that may not be controlled, and then we need the newer molecules that might help, or the newer modalities of treatment in that case. So these newer therapeutics that has come over like last 10 years, or that will be developed during the next 10 years, that will be discussing mainly on treatment. First and foremost part is definitely the lifestyle modification that has been discussed, the diet that has been discussed extensively by Dr. Mane. Again, that intake of sodium, that has been linked as a modifiable risk factors that everyone has to follow in their lifestyle. Then eating like eating vegetables, exercise is important component of that. Then control of other associated diseases like diabetes, that is also important. Now content of this talk, that will be mainly these drugs or newer therapeutic aspects I'll be discussing on, like direct renin inhibitors that has been coming into the picture these days, or that has been researched or being researched over the last 10 years, or that is coming into the market or on the commercial levels. ACE inhibitors, that has been the age old medicines. ARBs we have got since last 20-25 years. Then vasoactive peptides, this is another mechanism that will be acting on this and will be using this in the pharmacological armamentarium of ours. Then vaccines are also into the research. Then CCBs, diuretics, beta blockers, these are the age old medications, but newer molecules are coming into this armamentarium also, that we'll be discussing on. This is the most and important part of mechanism of hypertension that has been discussed by madam, and everyone has to remember, or that in the brain this part, the angiotensinogen, angiotensin 1, then angiotensin 2, and aldosterone, that acts at multiple levels, that leads to like sodium retention, water retention, increase intravascular volume, and that is mainly leads to a complex phenomenon, and that leads to the hypertension or heart failure. This hypertension and heart failure, that goes hands in hand, and that you have to analyze as a clinician. So this is the important various aspects of therapeutics that we intervene at this pathway. That is very important. Everyone has to know this. Again, this is the simplified figure. As we all can see that there are two more for the angiotensin 2 types of receptors are there. The type 1 receptor that plays into the hypertension, and type 2 receptor, that is, or alternative RAS pathway, that many of us may not be aware of. That is one entity that has come into the picture over the last 10 years, and these molecules are being developed on this pathway. The alternate RAS system I'll be discussing on. Now, first, newer drugs that will go by one. The direct renin inhibitors. The first generation and second generation, those were the research molecules, but they could not come into the market because of the different reasons. But the third generation molecule that is orally available, that is aliskiren, that has been that AC inhibitor, and along with the ARBs also. Okay, various trials are there. Other molecules were there. Mainly this molecule will be seeing on the commercial level. What is How is the bioavailability of aliskiren? This is orally bioavailable pharmacological part. It is only 2.5. It is 2.5%, but it has a high specificity and affinity for human training. And this aspect we are like going into, because other previous molecules like AC inhibitors or ARBs, they were acting at some other level, and we are exploring various therapeutically. And what will be the important of this? Cytochrome P450 system is not very much involved, so that easily, like this, even if 2.5% bioavailability, it works very well. And once a daily administration is possible. This has been taken from the Lancet 2006, like when the research was going on. Then important aspect of this molecule will be, like at most of the time aliskiren will be used with the ARB like valsartan. That these trials have been this trial is there, that is published in the American Journal of Hypertension in 2007, and it is having the greater antihypertensive effect when it is combined with the valsartan, and that need to be combined, or combined drugs are available or coming into the market. Aliskiren and ramipril effect. Plasma renin activity is the important aspect that is significantly suppressed with aliskiren and ramipril. Ramipril that we have been using since a long time, and again this data has been published in this very important scientific session in 2007. Use of DRIs, possible implications in the myocardial infarction. It completely blocks the RAS pathway. Okay, renin is the first hormonal thing or biochemical molecule that acts on the angiotensin and converts it into the angiotensin 1. So when renin is only acted upon, that will be at the very first level, and that will be very important, because like this plasma renin activity a risk factor for myocardial infarction. The hypertensive patients, that uh, ACE inhibitors or ARBs, there will be the in excess of the renin in the body, and that will have deleterious effects on the cardiac tissue, or it itself will have deleterious effects. And when that can have the additional modality that has been researched, and when we act at the renin level itself, this plasma renin activity will be suppressed, and this will have additional positive effect or additional benefit to the patient. Many of the studies like additional therapeutic benefit of renin inhibitors that has on the cardiovascular or target organ protection that has been researched upon, and that's why this will have the additional effect when we suppress the renin. This is one of the important therapeutic aspect that everyone has to know, and that will be we will be using clinically in the patients. That is the important aspects. It reduces the plasma renin activity along with the ARBs on a greater extent. Now, age-old angiotensin receptor blockers we have been using as a first line of drugs also, like telmisartan or any, and we have been using successfully, and they are not having as such. They are safe and not having as such side effects. And many of the molecules are there in this class. Most commonly, right and left, we are using the telmisartan, and very safe molecule that with experience also and with evidence also. Safe molecule, less adverse effects. And why these ARBs were there into the market? Because ACE inhibitors, like they had a more adverse risk protocol, or they were like angioedema or cough. These were more common with the ACE inhibitors, and then these molecules like 10, 15 years back or 20 years back, they come into the picture, and we have been using them successfully in the treatment of hypertension, also in the heart failure, and they are helping us to prevent the cardiovascular events. Newer molecule that has come into the picture, the ARBs, that is azilsartan, developed by the Takeda, that is a well-known pharmaceutical giant. As a product, it acts various doses. They are there. Again, it has having a very good safety profile. It decreases the BP and very much good safety profile as compared to other ARBs, and but telmisartan is a well tested drug that we can carry on with the telmisartan itself. This is one of the important aspect. Vasoactive peptides, like many of the vasoactive peptides, like many molecules are there. I'll be one more figure is there later on in this presentation, that I'll be discussing mainly on various atrial natriuretic peptide BNP. This play a very important role when in the hypertension mechanism, and also in the heart failure mechanism, and that is degraded by the naproxen or vasoactive peptides. And if we target this level, so this ANP level and BNP level will be maintained. Sodium and sodium excretion would be there, and diuresis would be there, and that will be helping us out in treating the hypertension. And this is one of the newer molecule or newer level where we'll be acting upon various molecules in this range. Naproxen inhibitors that has been they are being tested in the clinical trials. The important molecule been tested like sacubitril and valsartan. This is combinedly used in the various trials. That is a naproxen inhibitor that we are discussing. Greater reduction in the systolic blood pressure than valsartan alone. Greater reduction in the symptoms, physical limitations, and cardiac death due to heart failure. Because for heart failure, or even there is a concept of heart failure with preserved ejection fraction, that may be subclinical in the clinical practice. Even that is going to help in these patients, and these physical limitations is like more improvement in these physical limitations, greater decrease in the BP, pulse pressure, and arterial stiffness in elderly. Pathophysiology of the heart failure. This is the again RAS system
Recording stopped.
maladaptive response, during which
Recording in progress.
renin pathway, that is very important aspect, and alternative renin pathway, that is now also being researched upon. So these are the molecules, like various aspects we can act upon, and we can have the newer molecules, more safe molecules, more important molecules that can have multiple pleiotropic effects we can get with all these molecules. That's why everyone has to know this RAS and alternate RAS pathways. That is very important aspects. RAS pathways we all know, but alternate RAS pathway, that is also equally important and very important in this scenario. Neprilysin, as we are discussing with this is very important, right? In the circulation, this study was published, combined angiotensin receptor antagonism and neprilysin inhibition. In the 2016 circulation, this was published, and this is the area of interest of scientists or working physicians, where we can act upon. Why sacubitril and valsartan? They are in combination. They are to be used in the combination. Valsartan is an angiotensin receptor blocker. It works on blocking RAS system. However, because of the neprilysin breaks down the angiotensin 2, and it breaks down the angiotensin 2. But when naproxen is inhibited, definitely it will increase the ANP and BNP level, but simultaneously it is going to accumulate angiotensin 2, and that can have the opposite effect on the mechanism. That's why valsartan combining with the sacubitril or naproxen inhibitor, that is very important aspect, and then you have to combine these molecules. Otherwise, only sacubitril will not have its desired effect. Key points to remember when you start this combined therapy, or when you start sacubitril: allow at least 36 hours washout. Washout of when you are switching from SE inhibitors, just allow that 36 hours of washout period. Patient must be able to tolerate SE inhibitors or ARBs. There was not no hypersensitivity reaction previously, that you have to take into consideration. Precautions, again, renal impairment, as we are aware that ARBs or SE inhibitors, eGFR is less than 30, then avoid these drugs. Hepatic impairment, particularly child per class C, or they are the only contraindications, or you have to take precautions. Child per class B, then you can use this. Pregnancies, better avoid these drugs. Breastfeeding women, avoid this drug. This has been detected in the milk in the experimental studies. Contraindication, as we know, hypersensitivity to this molecule, angioedema, as with SCE inhibitor and ARBs. When renin inhibitors, aliskiren, is that has to be avoided as a combined therapy, because that can have severe hypertension. Patient may land up into severe hypertension, hyperkalemia, or renal impairment. Now, the one more mechanism that is being evaluated is the endothelin receptor antagonist. Like in the primary pulmonary hypertension or pulmonary hypertension, we see that endothelin is the most potent vasoconstrictor that we have seen, and if you block that, then that can be the mechanism that might be used for the hypertension also, because many proliferative mechanisms that those play into the picture. There are two pathways here. We can directly block endothelin receptors, or we can block the conversion of big endothelin, that is the substrate, and that produces the endothelin, that is endothelin converting enzyme. We can block we have the molecules acting at on both these pathways, which we sparsentan, like I discussed, these are in the phase 2 trials still. They are the molecules. Those are being those are being used in the pulmonary hypertension also. They can be combined with the ARBs. And then important aspects. This randomized control trial, the Lancet, it's still ongoing. Sparsentan and irbesartan. Sparsentan in patients with IgA nephropathy that has been tested. A pre-specified interim analysis has shown that it is effective in reducing the proteinuria in IgA nephropathy, and this trial is ongoing. Now, dagleutril. This is the molecule that it is the endothelin converting enzyme inhibitor. This is being tested, and that has been found to be effective. It decreases the pulmonary and right atrial pressure without affecting the systemic arterial pressure, cardiac output, and heart rate. So this is another molecule that is very important, that will be coming that will be coming into the practice, say next 5 to 10 years definitely. And potential data is also available. This trial, randomized trial is that is done, and into the picture, these endothelin receptor inhibitors, that is having the neural endopeptidase inhibitor activity also, that acts at the 2 levels, and that can be helpful in the hypertension control. Now these two newer mechanisms we discussed, again we'll go back to the some of the age old molecules that we are having. Aldosterone, the most important aspect in the RAS pathway, that we know, that plays itself, and also it acts at the pituitary levels in secreting the ADH, and that can have the increased sodium retention, then sodium retention and water retention, and that can lead to the hypertensive effect. This is the diagram that we have been seeing. It is secreted from the zona glomerulosa. And one important mechanism that we can see, that endothelial dysfunction and in the vascular disease, that is also affected by the aldosterone. That's why this is important mechanism that we are acting upon, and many newer molecules will be there. What we have with the aldosterone receptor antagonist, spironolactone, but lack of specificity. It also binds progesterone and androgens. That's why it has the side effects. And but relatively, as I experience with this molecule, it is definitely relatively safe. It's not. We do not get routine side effects. You can use it, and that we are combining with the loop diuretics like lacilactone we have available. Then eplerenone, and canrenone. Eplerenone is available in the market. I have even personally I have been using this molecule in the resistant hypertension as an add-on drugs. It has given very effective treatment in my patients also, which I follow, like resistant or refractory hypertension. Few of the patients that I do get in my practice, eplerenone is a very good molecule in this resistant hypertension, and you may use this in the practice. Then some newer molecules into the picture also, finerenone. Then aldosterone synthase inhibitors. One more aspect that is being targeted is the aldosterone synthase inhibitor. This is like CYP, it blocks that aldosterone synthesis itself. This molecule, fedrozole, this is being tested. But what is the problem with this molecule? This will inhibit the like other enzyme that is important in the synthesis of cortisol also. So that is not specific for aldosterone itself. So then that was the need for the specific aldosterone synthase inhibitors. Like then these are also into the pipelines, LCI 699 and other one. If like primary molecule that is not specific for the aldosterone itself, that can lead to like decreased cortisol, and that can have the adrenal insufficiency. That can be like patient may have the clinical side effects of weakness, excessive fatigues, that you have to always consider when you are treating these patients. Like you have to have the minimal side effects when you are treating these patients. Disadvantage of aldosterone synthase inhibitors: hyperkalemia can be there, hyponatremia. Hyponatremia is very important aspect when you treat the hypertension, particularly in the elderly patients. Then you have to be a bit precautious, like when to start diuretics or when not to start diuretics in the clinical practice, because that can predispose to a very severe hyponatremia, and patient may land into emergency department with severe hyponatremia, or it's even it can be fatal. Then that's why this is the important aspects. And as already we discussed, that fourth or fifth line therapy in the resistant hypertension, very important aspect when we treat the resistant hypertension, or when we do come across the resistant hypertension patients. Like now, this is one of the important slide that I'll be highlighting. These are the important aspects: counter regulatory pathway or alternate RAS pathway that I was talking about in my previous slides also. This alamandine angiotensin converting enzyme 2. We all were aware of the angiotensin converting enzyme that is secreted by lungs. Like the left side of this figure, that you all see that this is the classical RAS pathway, that angiotensin is produced in the liver. Then ACE angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. Angiotensin then again has a angiotensin 2 has its role on various target organs, or mainly it is the vasoconstrictor, and that is the mechanism in the. But till now we were like only focused on this, but counter regulatory RAS pathway like ACE2, this is the enzyme that converts this angiotensin into the more favorable angiotensins, like angiotensin 1 to 9, angiotensin 1 to 7. And these are the angiotensin type 2 receptors that I was also previously discussing. These are the important that lead, and that can lead to this alamandin complex, then MAS receptors. All these are important in the vasodilation. These are the counter regulatory mechanisms that do exist in the body. We were not aware of these mechanisms. This is the area of interest for research nowadays. These are the various molecules are acting at these levels, and we are like various trials are going on these molecules. This is the important aspect that helps that those will be available for us to decrease the blood pressure and to like prevent the target organ damages. Like already discussed, this is the important pathway. This alamandin, a newer member of angiotensin family. This is there in with this paper, current opinion of nephrology in hypertension. Drug activity, we discussed this part. 80 type 2 receptors agonist. This will be the next target. ACE2. When I say angiotensin converting enzyme, the classical pathway, we have to have the inhibitors, and here we will need the activators, because this is a favorable pathway in the body and we have to act on that. Then angiotensin 1 to 7 analogs, then activator of the MAS receptor, and activate like agonist for the alamandin complex, because this is the favorable pathway. At least now everyone will be by hurting this pathway, because this is something that will be coming newly, and that will be these molecules will be available with us. 82 receptor agonist. This is a type 2 receptor which is having the favorable effect or vasodilatory effect that can be helpful in the hypertension or in the heart failure. This molecule, these compounds, C21, even as we have seen in the COVID pandemic, fibrosis was there, or proliferative effect was there. Even this was used, or in some few of the trials during the pandemic, because it is a proliferative and it is again, these pathways mainly are helping in the apoptosis and development of the fetal tissue. That is the mainly it will prevent the fibrosis in the end organs, and that can have its favorable effects on this pathway. Angiotensin converting enzyme to agonist. Here we need the agonist. These two molecules are in the picture. The names are difficult to remember because too many the research is going at in a vast way, and definitely science is the important thing where like we can elevate the symptoms, we can elevate the diseases because of science, and we also have to search for the newer molecules. We always need to have the data on that, safety data also. So these are the important things that we have to search for. Then these analogs, CGen 856, these will be the angiotensin 1 7 analogs at various levels in the trials. Like few of the preclinical trials are going on, phase 1, phase 2, phase 3. These molecules are at various. This is again AV0991. You just remember, or you just remember the mechanisms at what level we all will be acting in the development of the newer therapeutics for the hypertension. This is the at the mass receptor agonist level. Alamandin complex, very important last receptors or last molecule that acts in the vasodilatory mechanism in the alternate RAS pathway. Then you can see that hypertension is having very complex mechanism. It plays at renal level also, it plays at multiple organs, and definitely from the brain also there are many peptides which play important roles. As alternate RAS pathway we discuss, there are again fewer new molecules, those are coming into the picture, like angiotensin 2 converting into angiotensin 3, angiotensin 4 with the help of these aminopeptides, and that leads to the activation of the sympathetic nervous systems. Again, molecules at the central level also. This RB150, that will be the inhibitor of these enzymes, and that can reduce the sympathetic outflow from the brain itself, and that will help us in reducing the hypertension, and this will be again into the clinical trials. This molecule crosses the blood brain barrier, that's why it is being tested at this level at the centrally acting molecule. Vaccines are also there into the picture, like they act as a angiotensin 2 level antibodies do develop, and the effect remains sustained like up to 4 months. You can like these are into the trials. Patient can be like every 4 months, a patient can take a, if their safety limits is tested, patient can take this vaccine every 4 months, and they can be free of the drugs. That might be the area of interest for these vaccines that will be acting, because nowadays many of the clinical phenomena or pathophysiology in all the diseases that is going at the, mainly immunology is concerned at various places. The mechanism is already extensively discussed by previous speakers, and that's why this will be the area of interest for the researcher and clinicians who are treating the hypertension. Then we will go back to these calcium channel blockers, the age-old molecules, newer and old. We have to channelize both the molecules, like and we have to use precautiously, or we have to use justify their use in the clinical practice, and you have to have the experience with these molecules. Calcium channel blockers, good drugs that have been I have been using since last 10 to 15 years, more than 15 years. Safe molecules. These are the different types of calcium channels, and drugs do act on these different channels. L type most commonly, or previously used calcium channel blockers were acting on these channel. Then T type mainly concerned with the pacemaker, atrial cells, and Purkinje fibers. NPR type channels mainly in the brain, neuron, pituitary glands. These are the different types of channels, and drugs do act on these. Clemidipine is the third generation L type, the primary channel that is blocked. This is the molecule that has been available, mainly used in the cardiac surgery or in the severe hypertension, that pre-surgery or post-surgery that is developed, and it is a safe, it is easily controlled, just like it is more effective than the NTG or sodium nitroprusside that we were used to use previously.
कुछ कई कॉन्फ्रेंस में
due to
वो गए कुछ तो भी बहुत
hypertension, we
बड़ी
can use this
सर्जरी
molecule.
करवा खड़े रह गए अपन हेल्प भी करेंगे ना
Then combined L
मैं
type
मतलब
and T
तो
type.
कहीं भी रोबोट
These are
हम
various
जिंदगी
molecules
राहत
available.
कर रहा है
Benedipine or benedipine is like available in the market. The other have been tested upon. Then combine L and N type. This cilnidipine molecule that has come into the market recently, having a good effective value. Also, the safety profile is good. Like with the calcium channel blockers or amlodipine, the most important part was the edema. Patient used to develop the edema fit. That was the side effect that has been elevated by this molecule, and now we have started using this molecule on a large scale. Like advantage 24-hour BP control as effective as the traditional calcium channel blockers. Advantage of cilnidipine. Then cilnidipine will have greater reduction in BP and prevention of ankle edema that already we discussed. Decreased proteinuria in the diabetes patients as compared to amlodipine. First line of drug in the hypertension treatment. It can be combined with the diuretics also, and very important drug in the hypertensive management. Like ARBs and calcium channel blockers. Few of the trials studies, like in the Lancet 2004, outcomes in hypertensive patients at high cardiovascular risk factors treated with regimens. Few trials showed that amlodipine or calcium channel blockers are very important, but there is no evidence of increased MI risk with ARBs that has been demonstrated. But both are equally important molecules. Only what we discussed in the initial slides, like in the direct renin inhibitors, that can have the more favorable effects because it blocks renin itself, like otherwise which accumulates in the ARBs, and that can have deleterious effects on the end organs. That only the question or area of interest or area of research now that is available. Both these molecules are safe also and effective also. Diuretics, again, Lupa Penley diagram we can see various diuretics are there, like they act on the proximal loop. Then loop diuretics like Lasix that play into the role. Distal convoluted tubule hydrochlorothiazides, then aldosterone, or these acts at the collecting duct also. This is the famous Guyton diagram that we learned in our first MBBS itself. These are the various classes of drugs available in the diuretics. Loop diuretics, then thiazide diuretics.
I can help. No issues.
Then
What is your
thiazide like
problem?
diuretics, chlorothiazide. Chlorothiazide is more safe than the hydrochlorothiazide. Potassium sparing like spironolactone. This
Okay.
already we discussed. Eplerenone, all this aldosterone antagonist. Thiazides first choice in the RX of in the treatment of essential hypertension. But always remember that when I see in my clinical practice, if age is more than 55 or age is more than 60, I will not use the diuretic as a first choice of drug, because significantly it can even though in few patients, but it can lead to severe hyponatremia. You have to be precautious for this. Then like calcium channel blocker or ARBs or RAS pathway drugs, you can use
So what we can do is
as
we
a
can
first line
just
itself also.
come
Then
and
loop
meet
diuretics,
me
the importance
tomorrow.
in the severe hypertension
Tomorrow is
associated
Monday,
with
right?
CRF and CACF. Potassium sparing, we already discussed.
In
Aldosterone is very
Department
important,
of Homeopathy.
and its inhibition is a very important in the treatment of hypertension. And beta blockers. Beta blockers, like we have used extensively, say 15 years back or
Okay.
20 years back. Atenolol was still these are the safe, but like that will not be as a first line of drugs. Newer safer beta blockers are there, but as a first line of drug, you don't use it clinically, because it can have the cardio suppressant activity, and it can have deleterious effects. It also have the like in diabetic patients, you have to be precautious when using the beta blockers. Newer molecules are
Look,
there, like
the phone card that came
carvedilol,
to
which
you
carvedilol,
to that
labetalol, which
is
blocks the
on
alpha
tomorrow.
receptors, so beta
I
receptors
cannot help
also.
in
They
that
are they are also
because
available.
we are
Like
conducting a
labetalol,
webinar
even
today
I have been
and
using,
we are
like
hosting it.
rather than
So it is
NTG
not
nowadays
possible
for the
for us
severe
to work
hypertension.
today
I personally
on
I
the
also use
issue.
in my
You have
ICU,
to
labetalol in the
tackle
acute severe
that
hypertension.
for
Then
tomorrow for sure.
carvedilol,
And
that is
tomorrow you
having the
can come
more
at
favorable
11
effect in the
to Department of
uh,
Pharmacology. We can have a one-to-one
in the heart
interaction.
failure
And
patients,
after
and
that, we will
most evidence
see
for
how
decreased
can we help you, right?
morbidity and mortality in heart failure. So this is like more it is being used than metro or something like that.
Okay,
Then
you can
nebivolol,
manage
this
it
is again the
as
recent
yeah,
molecule
yeah,
recently approved for beta 1 selective blocker.
yeah. 15 days
It is
back.
having the
I told
nitrous
them
oxide
already.
enhancing effects like more vasodilatory action it is having. These are the this is regarding the beta blockers that is into the practice, and when to use and when
Okay.
not to use, and newer molecules, more safe molecules we need. Beta
Maybe
blockers versus ACE
we will
inhibitors.
come back.
Uh,
Don't worry about
Trials similar, both similarly decrease in the morbidity and mortality. Famous UKPDS study has shown in the BMJ, which was published very like way back in 1998. Both are effective, but again, as a first line of drugs, more safer drugs are now available that we can use into. Now, like we are like moving that, we have to see the safety profile, because which we have tested in the post clinical surveillance, or we have tested molecules clinically on a large population, plus need of newer molecules. Again, the pathway, like we discussed that naproxen inhibition we discussed. Now we can have the molecules that itself acts as a ANP or BNP, that will have like excretion, that will increase the excretion of sodium and water. These natriuretic peptide receptor agonists, these are being researched into. These are the molecules, they have been given names. They are not into the clinical practice yet, but area of interest is going at multiple levels. The development of these molecules or research is going on a vast scale, and we have to be prepared that we'll be getting more and more molecules for our use in the clinical practice. Again, this is vasoactive intestinal peptide. Now, as we discussed, yes, mainly kidney is there, brain is there, which is modulating the hypertension response, RAS system or alternate RAS system. But even at the intestinal levels, there are some biological molecules. Those do act in and play a role in the hypertension. Like this VIP, this acts, and it's agonist that will act at the intestinal level, and that will be having the positive inotropic effects also, this molecule. That is one of the advantage that is being tested in the trials. Then again, we have seen the various channels or pumps at the renal level. Now again, this is one of the interesting channel that acts, that is in the intestinal sodium hydrogen exchanger 3 inhibitor. This will, along with the dietary reduction of the sodium, it will act on inhibition of this pump, and that will help in reduction of the this will help in reducing the salt in the diet itself, like at the intestinal level also, and that will help in the hypertension, and that can be available say in the next 5 years, 10 years, and according to the its safety level. Then dopamine beta hydroxylase inhibitor, again research molecule. Prevents the conversion of dopamine to noradrenaline, acts on the sympathetic system, and helpful, that will be helpful in the hypertension. Then this is one of the things, soluble epoxide hydrolase inhibitors, that prevents conversion of lipid epoxides into dihydroxy lipids, and this is having positive effect on the BP control. Then it is having the favorable effect that prevents the cardiac hypertrophy, prevent the atherosclerosis, and now we have seen so many molecules, but the main thing will be to remembering the newer pathway, that is the RAS alternate pathway that has come into the picture in a large scale, and molecule acting on that RAS pathway, or like sacubitril molecule or daglutryl molecule, those will be coming into the that will be the recent future for all of us.
Yogesh, can we wind up in some minutes, please?
Yes. Few slides only. Yeah.
Thank you.
And these are the last few molecules. Those are into the pictures. Those have been used in the pulmonary hypertension. sildenafil that we have been using in the pulmonary hypertension patients, sildenafil, vardenafil, tadalafil. And this is the same few tables only, last of trials that is going on for all these molecules that has been listed in this table, what we have discussed in the last all the slides. And mainly aspects will be neprilysin inhibitor, then endothelin receptor inhibition, then AT2 receptor agonist, and a newer alternate RAS pathway. That will be the important thing. Newly approved drugs that are being into the practice. This is one table that is showing aliskiren, azilsartan, then clevidipine in the acute hypertension. Then cilnidipine is already available. Carvedilol, nebivolol, those are being used in the heart failure patients and hypertension patients. JNC 8 criteria is there for the treatment of hypertension, stage-wise treatment of the hypertension that everyone knows. Combination therapies we have been using since a long time. Various molecules we have been using in a combined way. And resistant hypertension, we have discussed this part also. A very important fourth, fifth drug like aldosterone inhibitors that already we are using, and newer methods we are into those are into the pictures. Interventional treatments, these are also into the trials. Renal denervation, baroreflex activation, that is into the picture. Carotid body ablation, AV fistula, that in the mechanism that was discussed, or in the epidemiology, fistulas were formed by the Hippocrates itself, like that was the age old thing, very too many years ago. Again, that is being into the practice, or that will be many and more trials are needed on these interventional therapies. Thank you very much, Dr. Zubair. Yeah. Hello.
Yes, sir. I can hear you.
Yeah.
Yes. Thank you very much, sir. You can stop sharing your screen.
Yeah.
So this is the memento that we have prepared for you.
Oh yeah.
And
Thank you.
it will reach you very soon.
Yes, sir. Thank you. Thank you very much. Yeah.
Yes, sir. You can stop sharing your screen.
Yes. I'll do it. Is it stopped or it's still there?
It is there, sir.
Just a minute. It is stopped, I guess.
Yes. Now I would like to call upon very senior consultant ophthalmologist of our city, Dr. Ehrar Khan, sir. He has got total of 12 papers, of which 3 he has submitted in CMEs of IMA and 4 in CMEs of Maharashtra and ophthalmology. Sir is a very dynamic speaker and a very motivated and motivating person. He is always at the back of most of the doctors that are working in the city. I request sir to kindly share the screen and take over the charge. हाँ हाँ, अब यहाँ पर बैठिए।
Thank you, Zubair, and thank you, Team Elliot, for inviting me for this talk. The topic as is already clear, you have seen it. Most of the hypertensive changes that take place in this, they take place in the eye in the posterior segment, that is in the backside of the eye. You see primarily these changes that take place are in the optic nerve, the central retinal artery, the central retinal vein, and the macular area. This is where the main drama of the hypertension unfolds. How does the eye react to hypertension? Simply put, in response to hypertension, retina and its vessels, they are influenced by three elements: the state of the blood vessels before hypertension, that is whether or not there is hardening of the blood vessels; the rate of development of hypertension, that is how fast the blood pressure has risen; and the ultimate level of hypertension, that is how much has the blood pressure risen. How the elements matter is dependent much on the age of the patient, as they manifest somewhat differently in the young age and the aged. Now, what you see on the right side is the fundus, the retina in childhood. The retinal venules and arterioles, as you see, are of equal width. Both are well stuffed with elastic tissue, and the arterioles also with muscle. They glisten regularly in the light of an ophthalmoscope, and a thin white streak of light reflecting off the central portion of the that is of the central portion of the arterial surface. It is simply referred to as the light reflex. As old age arrives, these fibrotic changes are advanced and are referred to as involutionary sclerosis. The blood pulses normally through these retinal vessels over the years. Both the elastic tissue and the muscle tissues are in due course replaced by fibrous material, which dulls the glistening arterial reflexes. The dulling is referred to as silver wire and copper wire appearances, although these terms keep turning up in textbooks, but we don't classically see it on ophthalmoscopic examination. But anyway, there is a difference between the appearances somewhat, which might be picked up by some kind of some senior ophthalmologist, but especially now with high definition technology, it is being picked up. After some time, the caliber of the arterioles too becomes slightly reduced. Thus, the shifting shines of the young retina gradually give way to a generalized dry coarse mottling. Finally, as the age decline arrives, these fibrotic changes are advanced and referred to as involutionary sclerosis. Here, what you see is an aging retina. The upshot, the how does the state of vessels varies? The upshot of all that is the vessels of the young eye, full of elastic tissue and muscle, will behave very differently from the rigid fibrotic vessel of an elder eye when it is exposed to hypertension. How? That we will see in a later slide. Rate of development of hypertension, just as the state of the vessels is important, matters also the rate of development, how fast it has developed. When blood pressure moves into the pathological range, it may rise slowly and moderately, or it may rise swiftly to unrecordable levels. The response of the eye is not the same in each case. The gradual and moderate rise, which is less than 200 to 120 millimeters of mercury. In the aging eye, again, we have to see these differences in the aging eye and the young eye. In the aging eye, the involutionary, that is sclerotic changes are exaggerated. Any muscle remaining in the arterioles goes into spasm. The fibrotic arterial segments remain very much as they were or even dilate somewhat. These irregularities are seen as the shift in the arterial reflex. That is, the arterial reflex, as mentioned above, which is seen as a white streak, it now somewhat becomes broadened. The shift is from a silver wire appearance to a copper wire appearance, as also its appearance changes. Differences now develop at the same time, differences now develop at the arteriovenous crossings, which are described in a later slide. There is thickening of the arterial wall, which is obvious only where it passes over or under a venule and gives the illusion of compressing it. These AV changes can be taken at the point where pathological evidence of hypertension is taking over from the physiological evidence of passing time. Exposed to the youthful eye, when the youthful eye exposed to that kind of level, as already mentioned, exposed to a gradual and moderate rise of blood pressure, young vessels protect themselves with involutionary patterns, which, although acceptable at 60, this involution must be regarded as pathological at 20. We should then not be surprised to see the typical AV changes as are seen in the aging eye. When there is a rapid rise in blood pressure that is greater than 200 to 120 millimeters of mercury, both the old eye and the young eye now go on to the next stage in the process with hemorrhages, as you see here, which are flame shaped, typically flame shaped hemorrhages on the surface of the retina, which following the pattern of its superficial layers. Soon, lipids oozing from the disintegrating nerve tissue accumulates usually around the macular hollow, following the pattern of retinal fibers, which impart it a shape of a star. Here, as you see, is what you refer to as macular star. When the rise is rapid in blood pressure, what that is greater than 200 to 120 millimeters of mercury, what we see is cotton wool spots, which are whitish fluffy patches on the retina. They start appearing in both age groups and they do eventually fade out with time. These are actually the debris of intra-axonal. These are actually the intra-axonal organelles of the debris of the intra-axonal organelles of the nerve fiber layer of retina, which indicates acute renal ischemia. Hemorrhages present in simple hypertension will, of course, become more florid and indeed may burst into the vitreous, as you see in the lower slide, that it has burst into the vitreous and caused vitreous hemorrhage. Rapid rise in blood pressure that is greater than 100 to 120 millimeters of mercury, whether the patient be young or the patient be old. Finally, the optic nerve, the head takes part and swells into a state that's called papilledema. Here you see the optic disc is totally swollen. There are other. This is the normal disc as you see it here. This one is the swollen disc where you do not see the cup at all. This is the optic cup. You don't see cup here at all, and this is referred to as papilledema. The grading of hypertensive retinopathy, we generally use a 4-grade system to identify the severity of hypertensive retinopathy. The grades range from 1, general narrowing of the arterioles, to grade 4, signs of severe retinal damage. As we have already seen, hypertension causes two types of changes in the retinal vasculature: arterial arteriolar constriction and arteriosclerosis. This is important to remember that there are these two kind of changes we see. Arteriosclerotic means hardening of the arteries. It's a general medical term that means the normally flexible artery wall is becoming hard or stiff. This occurs in long-standing hypertension. It is due to intimal hyalinization, medial hypertrophy, and endothelial hyperplasia. Here you see the 3 layers, and all these 3 layers, they undergo a change which makes the arterioles very hard. Arteriosclerosis is divided into 4 stages. There are 4 grades of arteriosclerosis. Grade 1 is broad arteriolar reflex and simple vein concealment. If you can make out here, you see there is the broadening of the reflex, and there is enhancement of the arterial reflex, and there is vein concealment. That is, you cannot see the vein at the point of the crossing. In grade 2, there is grade 1 plus deflection of veins as AV crossings, arteriovenous crossings. This is called as Salas sign. It is right here, the one below, the most on the left side. This the cursor is pointing to the Salas sign. Then come the tapering of the veins. There is tapering of the veins. This is called as the gun signs. And there is banking, that is dilatation of the blood vessels. And this is known as Bonnet's sign. This happens because the arteriole and arteriole and the venule share a common sheath. the common sheath, the arterioles thicker wall push against those of the venule, forcing the venule to collapse. This makes the venule form an hourglass shape around the arteriole, or as the other theory says, this results not from the compression from the arteriole, but from the sclerotic thickening of glial cell proliferation at the site where the two vessels cross. The grade 3 is grade 2 plus copper wire arterioles and marked changes at arteriovenous crossings. Retinal arterioles appear orange or yellow instead of red. Well, you can't surely make it out here, and I failed to find a very high definition of this figure of it from image of it from the internet. Grade 4 is grade 3 plus cerebral arterioles. Retinal arterioles look white if they have become occluded. This is known as silver wiring. Mild changes at AV crossings may occur in normotensive with involutional sclerosis, but severe changes are indicative of long-standing hypertension. Here you can clearly make out the silver wire changes. Arterial vasoconstriction, this is the primary response. As you have seen, the arteriolar constriction, the arteriosclerotic changes are somewhat, they happen over a period of time, but this is the primary response which happens immediately when the blood pressure rises. Its severity is dependent on the level of the blood pressure and the coexistence of age-related involutional sclerosis. The secondary effects are retinal vascular leakage, giving rise to edema and hemorrhages, and retinal ischemia. Now, it too has got 4 grades. You see here, it is somewhat difficult to make out, but you will see that this is the normal retina. This is grade over the normal vasculature. This is grade 1 changes. In the earliest stages, there is a mild generalized arterial constriction evident by a decrease in the ratio of the width of the retinal and to that of the retinal arterioles to that of the retinal venules. It is very evident here. You can see it here. In grade 2, there is severe grade 1 plus focal constriction. The focal, unlike the general constriction that you see here, there are focal areas that undergo more severe changes. Then what you see below is the later changes that will be discussed later on. In grade 3, you see grade 2 changes plus hemorrhages, cottonwool spots due to obstruction of precapillary arterioles, retinal edema, and hard exudates in the form of a macular star. The macular star that we have already seen while we were discussing the changes in the old age and the young age, sudden rise of hypertension. So these are the flame-shaped hemorrhages that we see. There is retinal edema, and finally there is disc swelling, as we have already seen. This is the grade 4 change, which is usually seen in malignant hypertension. To summarize, grade 1, there is arterial thickening, tortuosity, increased reflectiveness, silver wiring. Grade 2, grade 1 plus constriction of veins at arterial crossings, arteriovenous nipping. Grade 3 is grade 2 plus retinal ischemia, that is flame-shaped hemorrhages or blot hemorrhages and cottonwool exudates. Grade 4 is grade 3 plus papilledema. Diagnostic tools, I won't like to go much in detail about this. There are the 2 methods, the direct method, the direct ophthalmoscopy, This is the preferred method to the first one because it gives a very limited view that is only of the posterior pole, while the indirect ophthalmoscopy, it gives you a wider view even of the peripheral retina. Then the next investigation is optical coherence tomography or OCT. It is an imaging method used to generate a picture of the retina. The non-invasive method produces an image by measuring the amount of a dim red light that reflects off the retina and optic nerve. Optical thickness and coherence tomography can measure the thickness of the retina and optic nerve. Here what you see is the normal OCT, which describes the various layer of the retina, and it is a very simple procedure. Here you can see how it can be done in a very simple way. It is a non-invasive method. The current gold standard, however, is the angiography, is the fundus fluorescein angiography. The procedure is used for examining the circulation of the retina and choroid using a fluorescent dye and a specialized camera. Sodium fluorescent dye is injected into a vein in the arm or hand, and approximately 10 seconds after the injection, a series of black and white or digital photographs are taken of the retina before and after the fluorescence reaches the retinal circulation. Photos are taken approximately once every second for 20 seconds. Then less often, a delayed image is obtained at 5 and 10 minutes. Sometimes a 15-minute image is taken as well. A blue filter is placed in the camera, so only the fluorescent yellow-green light is recorded. The principle is very simple. That is, the dye shouldn't be found where it is found, and dye is not found where it should be found. That is, here you see a normal, what you see is here is a normal angiography. You see the dye should be in the blood vessels, so it is shining in the blood vessels. Suppose if there are leaks or some kind of pathology, you will see the white fluorescence in those areas. So the basic thing to understand is where it should be, it shouldn't be, it is, and where it is, it isn't, which often happens when the macula is totally ischemic. Complications. The Sometimes while other investigations resorted to are not regularly recorded to, but they are resorted to as and when indicated as ocular ultrasonography in hemorrhage to rule out RD. Complications is subconjunctival hemorrhage, uh, occlusion of the central retinal artery, occlusion of the central retinal vein, vitreous hemorrhage, non-arteritic anterior ischemic optic neuropathy, and adverse effects of anterior hypertensive drugs. Now, this is very unusual. Nowadays, it was actually very controversial whether subconjunctival hemorrhage is really caused by hypertension or not. But it is now established that the sudden presence of blood scattered over red area of sclera, which is known as subconjunctival hemorrhage, is usually due to is one of the causes of it is hypertension. Though hypertension is often associated, it is not exactly the cause unless there is a sudden rise of blood pressure to very high levels. Also, unless subconjunctival hypertension is subconjunctival hemorrhage is severe and the blood pressure is uncontrolled, hypertension isn't a cause of subconjunctival hemorrhage. Such uncontrolled hypertension patient is most likely to have other systemic symptoms. Hence, it is unlikely that in an otherwise normal patient, SCH should be the presenting clinical feature of hypertension. Nevertheless, in an already known long-standing case of hypertension, subconjunctival hemorrhage does occur even if the blood pressure is controlled with drugs, as it causes microvascular changes in the conjunctival vessels. It requires no specific treatment except tear substitutes if there is a scratchy feeling. Depending on the extent of the SCH, the blood gets absorbed in 8 to 10 days or at the most 2 weeks. Here you see specifically that it is turning yellow. You have to tell the patient that while it is clearing off, the eye may turn yellow and the patient may not get scared or think it to be due to jaundice, which is usually what patients think. Central retinal artery occlusion, interruption in the arterial flow leads rapidly to the total retinal infarction. The retina normally is transparent, clouds into opacity, except at the macula where the cherry red spot choroid can be seen through the macular flow. You can see that the whole of this is very opaque, which is usually transparent, and right in the center, you see a cherry red spot. This is the classical sign of central retinal artery obstruction. At the very outset, it is very one should know very clearly that there is no standard treatment for CRAO. There are invasive and non-invasive managements that have been tried without much success, or the fact that any treatment has essentially to be administered in less than 2 hours of the onset of loss of vision. The goal of each non-invasive treatment is to increase blood flow and blood oxygen content. Most invasive procedures are aimed at reducing intraocular pressure and to lyse or dislodge the obstructive embolus. The first one is the very simple one. It is the ocular massage. It can dislodge the embolus to a point further down the arterial circulation and improve retinal perfusion. Pars plana vitrectomy with direct central retinal artery massage invasive. Ocular massage, as here you see, is the in and out movement with 3-mirror Goldman contact lens or digital massage. This is usually done by the could be done by the ophthalmologist. It can dislodge an obstructing embolus, increase pressure for 10 to 15 seconds, followed by sudden release. There is an 86% increase in the volume of the flow. One has to keep in mind that even if you are digitally pressing from one end to the other end, you should not press it very hard. It should be a very slow 10 to 15 seconds for a very short time, a movement of fingers from one to the other end or the tip of the with the tip of the finger. The pars plana vitrectomy with direct in central retinal artery massage. It is an invasive procedure. A probe was designed to apply direct gentle pressure massage over the CRA and the optic nerve head. Of 10 patients, circulation was restored in only in 4. One of the commonly employed at general practice level, at a clinical level by most of the practitioners is anti-chamber paracentesis, which is an invasive method. A 0.5-inch 30 gauge metal is as a tuberculin syringe without plunger is used. Needle is placed between iris and cornea. Here you see between iris and cornea, not in the pupil. It should not go in the pupil. Central corneal pressure stabilizes the eye and facilitates removal of aqueous humor from the antechamber, which causes a decrease in the intraocular pressure. This is believed to allow greater perfusion, pushing emboli further down the vascular tree. Medical reduction of intraocular pressure. This is non-invasive. Acetazolamide 500 milligrams intravenous or 500 milligrams per oral can be administered to immediately lower the intraocular pressure. Topical medications are also used to lower intraocular pressure. They act by decreasing aqueous humor production with bitter energy blockers or carbonic anhydrase inhibitors, or increasing outflow with prostaglandin analog or alpha agonist. Laser embolectomy. This is again an invasive procedure. Lysis of the emboli can be achieved with neodymium YAG laser. Retinal perfusion with gain of visual function can be achieved. However, complications such as creation of false aneurysms and vitreous hemorrhage may arise. Intra-arterial fibrinolysis is again a non-invasive procedure. It has been used anywhere from between 1 hour to up to 24 hours, although this procedure is still very controversial. Thrombolytic agents have been studied for CRO, the thrombolytic agents that have been studied for CRAO treatment include intra-arterial tissoplasminogen activator, TPA, and urokinase. Just like the paracentesis, hyperbaric medicine is again has remained a popular treatment. It is effective in the first when the patient has come to you in less than 2 hours. The basic thing is the inhalation of the patient is made to inhale 100% of oxygen at 12 atmospheric absolute provides an arterial PO2 of 1000 to 1200 millimeters of mercury, which results in a threefold increase in oxygen diffusion distance through ischemic retinal tissues. It must be kept in mind that these patients are all usually are also having some multi-organ problems. So these should not be tried in an isolated institution and should other organs should also be taken into consideration, and there should be a team of specialists available around the clock. Intravenous methylprednisolone, which again is a non-invasive method. A single dose of intravenous methylprednisolone of 1 gram has been reported in a case series of patients whose vision failed to improve following the conventional treatment of measures to reduce the intraocular pressure. The possible mechanism of action is reported to be a reduction in the retinal edema and hence improvement of vision. Management of central retinal vein occlusion. Here, as you see, the disc is swollen and hemorrhages dominate the appearance of an equally swollen retina. Should the oxygen supply be compromised, and it is not always, the eye may respond as it does in diabetes, often an associated disorder with new blood vessels sprouting out over the retina and creeping over the iris root into the drainage angle where it may block aqueous outflow, turning the eye into a visually useless ball of pain and redness by causing close angle glaucoma. Here you see is the classical CR view. What you see here, down here, this is the formation of new blood vessels, new vascularization of the organs, and this is the angle. The angle is blocked due to these new vessels, due to which the aqueous cannot flow out, and as a result of that, glaucoma develops in the eye. Management of central retinal vein occlusion in patients who receive no treatment, about one-third improve on their own, about one-third waxen vein and stay about the same, and about one-third get worse. If there is macular edema, it may improve on its own, especially in the young aged patients compared to elderly patients. Commonest treatment is periodic injections into the eye of an anti-VEGF, that is vascular endothelial growth factor. These drugs include Avastin and Lucentis. Avastin is very commonly used and it is the cheapest, and studies suggest that it has got all these molecules have got equal effect. Avastin is cheapest among them, so one can definitely opt for Avastin. Their effect in the eye wears off, so re-injection is often needed. A rare lucky patient needs only one injection, but the norm is a series of periodic injections over the course of a few years. Management of continuing the management of central retinal vein occlusion, intraocular steroid intravitreal injection of triamcinolone or a small steroid pellet called dexamethasone implant. The steroid injections typically last several months, but can cause elevated intraocular pressure requiring eye drops or increased rate of cataract formation. This is also commonly used treatment. Uh, the injection of the triamcinolone, and it is quite effective too. Laser photocoagulation is considered to be the first line therapy for treating the compilation of the retinal vascular disease. There is pan retinal